Okay, so officially, I am Amanda Perez, and I'm with the Center on Brain Injury Research and Training here at the University of Oregon. Thank you all so much for joining us today. A couple of housekeeping things, and we'll just keep that brief. We have a chat function for this particular webinar, and I know many of you have used it already. It's at the bottom of your screen. We're also going to be using Q&A. And I would encourage you as we go along, as you have questions, please write them as you have them. There'll be a Q&A opportunity at the end of today's presentation, but we don't want you to lose track of those questions and save them all for the end. So please write them down as you think of them. We will save them and we'll make sure that we ask Sharon those questions as we get there. If you do run into any issues, if you didn't get the handouts that I emailed out, or if you need any of that, you are welcome to email me directly. I will be monitoring my email throughout this. We'll put that here in chat, and my email is pereza@siebert.org. You can look for that in chat here in just a moment. I'll put that in there. And with that said, I'm going to briefly introduce Sharon. So Sharon Grandinette is a certified brain injury specialist and trainer, and a nationally and internationally recognized consultant who focuses her work on school reintegration for children with acquired brain injury. She has worked in public schools as a special educator and administrator for over 25 years, developed and administrated 2 private special education brain injury schools, and spent 3 years as the director of Children's Post-Acute Brain Injury Rehabilitation Program. Sharon was an adjunct instructor in the Graduate Special Education Credentialing Program at California State University Dominguez Hills for 18 years, and she's written multiple articles and a book chapter on the topic of children's brain injury. So with that, Sharon, thank you so much for joining us, and I will turn this over to you.
Thank you, Amanda, for that wonderful introduction. And I am so excited to have people here from across the country. You know, people say, what do you do for work? And I say, I don't work. This is my passion. So I want to share my passion with you today. We're going to be talking about working effectively with students with moderate and severe acquired brain injuries. And my goals with you today are to have you learn the unique presentation of children with various types of moderate to severe acquired brain injuries. We're really not focusing on the mild today. And how we're going to identify and address cognitive and physical and social access needs of these children who are nonverbal and have limited to no motor skills. And I want to hope to help you learn to appropriately direct the management of students whose healthcare needs impact their educational access we're going to be talking about implementing different sorts of healthcare plans and working collaboratively with the children's treating physicians and therapists, the school nurse, and then look at and put into practice the current research-based strategies that are really effective for these children in the academic, social, and neurobehavioral challenges that they present with. So this is one of my favorite slides. It's out of the state of Wisconsin Department of Public Instruction. And I like to say, I will say I stole the slide, but I added the umbrella. And the reason I added the umbrella is because brain injury is really an umbrella term. And as you can see, we have on one side the congenital and perinatal causes of brain injury, where these children have no period of normal development. And I will say that for most of us who've worked with children with special needs, we've been doing this for many, many years. We understand this population pretty well. But on the other side, under brain injury, we have acquired brain injury following a period of normal development. Now, I often get this question, how long of a period of normal development? Well, if you look at the definition of brain injury under education code, it basically says it just cannot be through the birth process. So technically it could be a child who's 2 hours old who was dropped. But for most intents and purposes, you know, it's nice to have children with acquired brain injury who've had some period of normal development that we can really measure pre and post functioning. Under acquired, we have non-traumatic, which I'm going to explain in a minute, and then traumatic, which is those external physical force, and that can either be an open or closed. Now I have a little star here, and if you look at the bottom left screen, you'll also note that TBI also includes drowning or near drowning. A lot of people aren't aware of that, so I wanted to make sure that I highlighted it. Now this slide are the children who have causes of brain injury that are acquired that are non-traumatic. Now, I laugh at this non-traumatic because people say, my child had a stroke, how is that not traumatic? But it's not from an external physical force. So the ingestion of toxic substances, medication errors, metabolic disorders, anoxic and hypoxic injuries, different than near drowning, infections like encephalitis, meningitis, seizures. Sometimes seizures are a standalone neurological insult. Brain and central nervous system tumors, which I spent a lot of time working with children with those particular issues. And then to follow that, children with all kinds of cancer who are treated with chemotherapy and what those late effects look like. So on this slide, I put together this slide for you so that you could see how we figure out how to rate a brain injury. Now, we don't do that in the education world. This is done in the medical world, but you can see mild, moderate, and severe, and you can see the length of loss of consciousness, post-traumatic amnesia, meaning that they don't remember things following the injury for a certain amount of time. We use the Glasgow Coma Scale, and as you can see here, 3 to 8 is very low, and that's where the severe falls. And then following that are possible physical symptoms. Oftentimes in mild, we don't see any physical symptoms, but under the moderate to severe, we will see them. And then another scale that we use is called the Rancho Los Amigos Scale of Cognitive Functioning. And I really like this slide because it takes you through the little road all the way down from one where there's no response, the person's in a deep coma, all the way through to level 9, which is purposeful and appropriate, and pretty much, we would say hopefully back to a typical development. Well, what's interesting about this is that all these different levels, we would hope people move through these levels, but there are children and adults who may stay at a specific level. And we tend to see those children who fall in the moderate severe range stay within the lower levels and do not progress. And when we look at the common issues of mild injury versus those with moderate severe, you can see while mild brain injury has cognitive communicative issues, has psychosocial and emotional issues, and has physical issues, they're not as intensively apparent as those in those children who have moderate severe needs. And you can see the list is very long for those children with moderate severe. And so when we measure those severity outcomes after acquired brain injury, we also have to be really realistic. I like the medical model, but we're educators. So let's look at the current practice, though, is not to just rate a brain injury as mild, moderate, or severe, but instead let's determine if the brain injury has a mild, moderate, or severe impact on that child's functioning. And there are several factors that help us predict the level of recovery for children who've had moderate severe injuries. We can look at the force of the trauma and the severity, the brain functions affected by it, the areas of the brain that are not affected by the injury, the Swiss cheese phenomena, I like to call that, their age at the time of injury, and many children with more moderate severe injuries also have other injuries to other parts of the body that also have to be taken into consideration. For example, children who may have a spinal cord injury as well, or people who've had a neck injury and pain from other events. Individuals who acquire a brain injury from non-traumatic causes, like the slide I showed you a minute ago, though, can also have a mild, moderate, or severe impact on their functioning. And so I have my little brain with the question mark down there, because does that mean everybody fits into one of those boxes? No. Every brain is different, every brain injury is different, and every individual responds differently. And one of the things that one of our colleagues who works in the brain injury field is very well respected, Dr. Sandy Chapman, came up with this wonderful image to help us understand what happens for children who have moderate to severe brain injuries. They are at risk for what we call neurocognitive stall, typically during the second phase of what we call brain injury recovery. And I always put recovery in parentheses, because when we use the word recovery, people think that the child is going back to who they were before. And we know that that isn't always the case, especially if we're 2 years down the road after injury. You don't want the child who was injured at 5, who's now 7 to be at a 5-year-old level. So it's important to keep that in mind. But despite often remarkable recovery during the first year after traumatic brain injury, because her research was in traumatic brain injury, but we can apply it to other forms of acquired brain injury, they tend to hit a wall or a plateau, and then they don't acquire expected developmental milestones. And then beyond a year, we see a halting or a slowing of later stages of cognition, social, and motor development occurs. And this may emerge despite a child seeming to have appeared to recover cognitive abilities equal to their pre-injury level. They were 5, but now they're 7. So I'm going to take you through 2 cases today of children that I have worked with. These are their real photos. I have permission to share with you about them. And this is Alex, or short for Alejandra, and she had a cerebral vascular accident or a stroke. That's a moderate level of acquired brain injury, and she was a typically developing child until about age 11. She played soccer, she rode horses, she was a good student. As you can see from this picture, she was just a happy kid. And what happened to her is she had a right hemispheric stroke at the age of 11 due to a condition called central nervous system vasculitis, and it's an inflammation of a blood vessel wall in the brain. So her right side was damaged, so her left side was then affected. And if you look at this diagram, you can see what happens to children, or adults for that matter, who have a right cerebral vascular accident. So a paralyzed left side hemiplegia, spatial and perceptual deficits. They minimize their problems because they don't realize they have them. Their attention span is short, their visual field is impacted, their judgment is impacted, they're impulsive, they don't understand time. And they have, you can see, I don't feel where my left side is, the left neglect. And so we will see that. And Alex, like many students who experience a moderate to severe brain injury, have a disruption in their education due to extended periods of hospitalization and rehabilitation. So here's Alex's journey. She spent a month in the hospital. She went to outpatient rehabilitation and had occupational physical therapy, counseling, speech therapy. And this was 6 hours daily for a month. And then they went down to 3 hours daily for 2 months. And she had home hospital instruction, or homebound instruction, initiated about an hour per day for 2 months, when therapy time was finally reduced to 3 hours a day, because you can't have a child in therapy 6 hours a day and still expect them to do school at that time. School asked the treating physician to complete the acquired brain injury moderate severe temporary accommodation form. And here's what it looks like. And all of the handouts that are attached to what you will receive includes what you see on the handouts that I will show you. And this form is acquired brain injury moderate to severe temporary school accommodations plan. And our goal is to have the physician fill out the top, and then we get that, and we go through, and as a team, we try to figure out what accommodations we need in the areas of attendance and breaks and visual stimulus and auditory stimulus, schoolwork, testing, a plan for emotional development and physical activity. Yes, even when the child is on homebound instruction, because we want to be sure when it's time to get them ready to come to school and have all of our information. This is the second page. It also talks about extracurricular activities, and unique to many of the children with moderate severe, the medical needs. And we also want to make sure that the RN at school is involved with this, that a student study team is held to go through this, and we will follow through. So what we did with Alex is, now, I know that we're all doing virtual meetings today and during these times of COVID, but because mom was at the hospital with her daughter in rehab all day, she couldn't attend a school meeting. So we did a virtual student study team meeting, and it was by phone because we didn't have all this fancy stuff a few years ago. But we had this early in her rehabilitation, and we included a review of her medical and therapy records and phone conference with medical rehab case managers and parent. And the student study team determined a need for special ed assessment. And the assessment included a review of all her medical and therapy records from where she was being treated. And the assessments were administered by the school team, and the rating scales were completed by the parents. And don't forget the home hospital teacher. And the teacher also provided us some work samples. During the whole process of this evaluation, she continued with homebound instruction. So the assessment found, with her cognitive profile, a past history of academic success, she relied on all her old styles of learning, but they didn't work anymore, and she got very frustrated. We saw a combination of unique conditions resulting from her acquired brain injury, but different than students with a specific learning disability or developmental disability or emotional disability. Her full scale IQ was a 90, but it was a very uneven cognitive profile. And some of her pre-morbid high level skills were intact. And then she could not understand why she had problems performing lower level tasks. And in fact, some of the teachers had a difficulty understanding it and said, oh, she's faking. She had a very inconsistent pattern of performance. So in her case, she actually retained a lot of her previously learned base of information, and that helped with relearning rapidly. But learning new information was extremely difficult. And she had a lot of difficulty comprehending large amounts of unstructured information. She had a slow processing speed, attention and concentration issues. Pragmatics were one of her weakest areas. She really missed the point of conversations, and that caused a lot of difficulty interacting with her peers, which led to some social and behavioral issues. She missed the details of an event. She didn't get the gist of what was going on. She had difficulty reading comprehension for longer passages. And the gist deficit didn't just apply to her social pragmatics and socialization, but with actually all of her schoolwork. And she had significant executive functioning deficits. And I really like this slide. This really helps put executive functioning deficits or challenges into perspective. So this gives you the circle. It's round and round we go. Where does it stop? It all feeds into the other: action, memory, emotion, effort, focus, and activation. And these are very important. You can have a child with 112 IQ, 120 IQ, but if they have executive functioning deficits, they may not be successful in school. Her critical thinking skills fell into the borderline range, and this was really a very difficult area. As you can see from the list of the issues that she had, take a look at those and try and determine how she could be successful in school with all of these issues impacting her functioning on a daily basis. Then the part that maybe some of us aren't quite so used to in dealing with children who have more moderate to severe brain injuries, the physical profile. She had the left-sided paralysis or weakness, so she had very little use of her left hand or arm. She wore a left foot, ankle foot orthotic, uneven gait when she walked, difficulties with self-care in the bathroom and at home, and changing her clothes and brushing her teeth. She easily lost her balance. She had difficulty pushing her chair in. She had difficulty holding her paper when writing, so she'd write and it would move across the table. And she couldn't open her locker with a combination. And I know a lot of schools have done away with those, but not all. And then we had to look at her medical profile, because as a result of her stroke, she also ended up with a secondary issue called epilepsy. And she needed appropriate seizure management, medication management, awareness of the medication side effects were important to know. She also, because of her condition and her seizure, she had to avoid heat exposure, and she lived in the high desert of California, where it was hot very often and outdoor activities were difficult. She had a very significant increase need level for hydration, and therefore she needed the restroom more often, and higher than usually excused absences because she was still following up with her doctors, her neurologists, her neurosurgeons, and all of her therapy appointments that were less than 3 hours a day, but still needed. And if you look at that, that's a brain scan of a person who had frontal lobe epilepsy. So the outcome of the school assessment is that Alex qualified for special education under other health impairment due to a cerebral vascular accident. Now, when we talk about eligibility for special education, most people would say she had a brain injury, so she must have then be eligible for a TBI, a traumatic brain injury. Unfortunately, a TBI educational definition says it has to be an external physical force, as I mentioned earlier. And in the state of California, where I am and where Alex is, we follow the federal guidelines. But there are some states in the United States, such as Ohio, where I know a friend named Sarah is watching today, and they tend to use other health impaired, acquired brain injury for all kids with all forms of brain injury. The assessments determined she met criteria for direct services for language and speech OT and adapted PE, consultation services for PT, she didn't need direct service, health and nursing, and assistive technology. And they performed a functional behavioral assessment. And because of all her social issues, because her critical thinking skills were so poor, she needed a positive behavior intervention support plan. So we held her IEP, we wrote goals in the areas of what you would expect: academics, of course, and of course OT-PT and OT speech and adapted PE. But we also wrote goals in areas that people don't think about: executive functioning, and we had actually 4 in that area. We had one for increasing attention to task, we had one for initiating a task, we had several for behavior that went along with her behavior plan. And she had a lot of accommodations, which I'll show you on the next slide. So where was she receiving her education? She received specialized academic instruction in a mild, moderate, self-contained classroom for her core academics, and then went to general ed electives with supports. And those supports included making sure that her staff and the peers, actually, we held 2 separate trainings on acquired brain injury and how this had changed Alex and how you could be a friend to her, and teachers how you could work with her. She had a shortened day to begin. She had a paraeducator to support her physical and safety needs. She had health and nursing services and an individual health care plan, which I will share with you, and transportation to and from. So given her unique needs, there were 4 documents that we used to help integrate her back to school. The first one was a specially designed school reintegration plan. The second, a healthcare plan with a seizure log. The third, a passport or a student profile. And the fourth, a specially designed homework log. So I will share with you those with you now. I developed this school reintegration plan for Alex, and it really was used while she was still in rehab, and we were trying to figure out what we needed to do first to make sure we put everything in place. And what we found is we would put down the item that needed to be accomplished and who was responsible, and then what date it was completed by, and when it had to be completed and when it was completed. And at the bottom, we listed all of Alex's team members, their names, their phone numbers, and their email contact. This is a sample of her healthcare plan that we put into place. This is actually a combination of a healthcare plan and an emergency care plan that we put all on one page. And this was for her nursing diagnosis because she was at risk for further neurologic impairment or function. And she was at risk for seizures, of course, and we had to know what her medications were, and we had to know how to manage her seizures and when to call 911. So this is a sample of her healthcare plan. This is a seizure record that I adopted from a rehabilitation center that I worked with, but I changed it a little bit and made it easier to use by putting the numbers instead of having to write down what was happening in the while the seizure was taking place. And then I also designed this, and there are many different versions of this that people use. I call it a passport back to school, passport into general ed, passport, or a student profile. And basically what this did was it really helped to share Alex's history, her eligibility, her physical and health concerns, her physical and health requirements. So everything that I mentioned earlier, it refers you to her healthcare plan, what her current functional levels were, what the areas of concern were, And then most importantly, the key academic strategies and accommodations. And I'm not going to go through those now with you, but you can see that. And you can also see that I did give you one as a handout, and you can go through and make it your own. So the other thing that Alex required was consistent use of graphic organizers. Consistent. I'm going to say that many times because I walk into classrooms, I see them up on the walls, I see them piled in a pile on the teacher's desk, but I don't see the children using them. So why? The key facts or information are highlighted for review across the curriculum. They promoted elaboration or organization of information to make it more memorable and also to help her get the gist. Remember the gist. And how do we do this? Well, first of all, we actually had to teach her how to use these. We actually had to teach the teachers how to teach her how to use them. We made sure it was required as a part of her assignment. It was part of her grade. And multiple copies were kept in her notebook at all times. She had to be cued to take them out to use them. And actually, they turned out to be so successful that the teachers started using them with all the other kids because they found how valuable they were. And then this is a sample of the daily homework log that we put together specifically for Alex. And you'll see it's a little more detailed than just those reminder binders we use or even what we use online for a lot of the kids now. But it says, here's the homework, here's the page numbers, here are the problem numbers, here's the materials you need at home. Did you finish it? Because she couldn't remember whether she did it or not. And then any comments mom wanted to make, teacher wanted to make. So that is a sample of that for you also. Now, Alex is in school. She's now there 4 weeks on a part-time basis. And we found out a whole lot more about her having her in school than we did just with the assessments. So we found that she had inconsistent patterns of performance, including day-to-day variability. So she could do something on Monday and she couldn't do it on Tuesday. And what did the teachers think? Oh, she wasn't trying. Uneven progress, periods of rapid learning followed by plateaus. She had inefficient problem solving and repeated mistakes, especially in math, and problems with generalizing, integrating, and organizing new information. But the biggest piece were the social emotional concerns. Even though we'd already had the functional behavioral assessment, we hadn't done it while she was in school, and it had to be revised. So look at the list of issues that she was having in school with regard to social and emotional issues. And let me just tell you, these were extremely problematic. And she was also eloping at times because she couldn't handle many of the issues. She wanted to be who she was before, and this was very frustrating to her. And Alex actually, when she sat down one-on-one with the school psychologist and myself, we talked to her, and here are the things she shared. I have trouble making up my mind. I get nervous when things don't go right for me. It's hard for me to sleep at night. We didn't know that, and we found out sleep was an issue. My schoolwork is not as good as it was before. She had been a good student. Other students seem to be able to do things easier than I can. Big one. I feel like crying many days. My feelings are hurt when I get fussed at. I'm sad many times. I miss the old me. If you learn anything today, keep that in mind. That's what these children are going through. Parents too, by the way, they miss their old child. So we reconvened the IEP, we revised the support plan, to address social emotional issues, we added daily expectations and self-reflection form, which I'll show you in a minute, to also assist with executive functioning deficits. We added counseling goals, services, and consultation with a treating psychiatrist. We added social goals that she attended a weekly group. We added duties to train the paraeducator to address appropriate social skills, especially during non-class times like passing, nutrition, lunch, PE, and to and from bus and on the bus, because she was getting into a lot of trouble on the bus. We also added a daily use of a homeschool communication log, and we added extended school year because she would show regret. We figured out she would show regression if she were not attending. So here's the first thing we came up with. This is a form that was on her desk at all times. It was for her to fill out. And the rules we had for her, the expectations: do my best work, complete my work during the lesson, use my blue folder time to complete unfinished work because her processing was slow. She didn't get everything done when everyone else did. Use my words to share my feelings, ask for a break when I need one, and here are the things she wanted to work for. And then she would rate herself, math, writing, recess, reading, and how she did, whether she finished something, if the work went in the blue folder, because again, she wasn't remembering. And then page 2 of that included all of the other activities for her day. And then she'd check in during the day. How are you feeling? Mad, sad, scared, frustrated? What can I do? I can ask for help. I can take a break. Or we had a form called a hassle log, and we'd go through it with her and have her process what had happened. And then she'd rate her school day, what she needed to bring home, what she was going to do after school that day, because her parents were separated. So was she going to her mom's or her dad's? And if she couldn't remember, if mom showed up and she thought her dad was coming, it would cause a meltdown. And what she needed to bring to school. This completely made a big difference in her life. So very important. And then we used a school to home daily communication log that we designed for her. And this really was filled out by the teacher and the aide. And we have to be careful to have aides write things, but it's okay for them to circle certain things, and that depends on your school. But as you can see, we went through all of this, all the classes, how her behavior was, what she had difficulty with, were her medications given, did she have seizure activity, if yes, see the log, and what to praise her for. Make sure you're always sending good information home, because mom would say, I asked her what she did learn today. I don't know. And we wanted to have a good communication. Now, this can also all be sent via email now. Then we had a home to school daily communication log, because Alex couldn't tell us what was happening at home. And so we had the parents fill this out, and it took a while to get the parents to comply, but they finally did. And it didn't come every day, but it was helpful. So staff had to be aware of Alex's impulsiveness. The other thing that was going on with her was she was making false accusations that males were doing certain things. I can see the sun is shining in right now, and so I look like I'm going to heaven, but I'm really okay. She had confabulation. She'd make things up that didn't really happen because she didn't remember. So she would start what she remembered, make up the middle, and everybody thought she was a liar. Verbal interactions that set off other students. She needed self-care in the bathroom and ability to express her needs and feelings. Saying, my mother said, and if it wasn't in the log, mom didn't say it. And then saying a task is too easy, or a desire to hide her left hand, which she did a lot because she had left neglect, and we had to cue her to use it. So that was Alex. I'm gonna turn so I'm not so blinding. Okay. Oh, that didn't help all that much. Put my head right here. Okay. So now I'm going to tell you about my other friend, Chris. Chris was typically developing until a severe TBI due to a near drowning at age 7. And this is Chris, 4 months in subacute and acute care, acute and subacute care, and then 6 months in inpatient rehab. And the school, unfortunately, before I got involved, put him on a 504 plan with a general ed home hospital teacher for 2 years. I have a sad face. Chris is considered a medically fragile student with a very severe brain injury. He had severe orthopedic motor deficits that were managed by a wheelchair, a stander, a changing table. He had a baclofen pump for managing his spasticity that's implanted. He had therapies, stretching exercises, upper and lower orthotics, a G-tube for his feeding and meds, muscle spasms, which people used to think were seizures but weren't, tons of chronic pain. We used the rating scale at the bottom to have him help us figure out what was going on. Fluctuating fatigue, which was both cognitive and physical, and he was also at risk for skin breakdown, pressure sores, and infection. Okay, this is a handful of trying to work with a child like this in the classroom. This is an example of what the baclofen pump looks like, and many of you are familiar with G-tubes. So how do you assess a student who has no motor skills? Well, his eyes worked. So we began with blinking for yes and no. We determined he could read, but the processing was slow. He fell asleep a lot. Using a very large whiteboard, we asked questions and then placed 2 pictures, written answers, one on each side of the board. He gazed at his answer. His head movement was slow, but he would make his selection. We then moved to a computer with a question written at the top and 2 photos to choose from with his gaze response on the left and on the right. All of this, as you can imagine, took an incredible amount of time. His road back to school, he was found eligible under traumatic brain injury. Remember, near drowning is a TBI. And we developed the IEP. We addressed academics, gross and fine motor, communication, social, emotional, and behavioral issues. We developed for him as well a school reintegration plan, but his was a really fluid document. And that's because he was having so many medical issues. He was in and out of the hospital for many other medical complications. And we also developed a healthcare plan for him as well. So this was his initial, you'll see initial school reintegration plan for Chris. And his was actually 3 pages. I didn't give you everything. I think one of the things that's important to notice is that we held weekly team meetings when he came back. And then we held first, second, third, and fourth weekly team meetings, and then every other week, and then we were going to once a month. And we held IEP meetings as needed to make changes because he was changing so rapidly and was having other needs that were appearing. And this is really interesting. His healthcare plan was so intricate that it literally had a table of contents. And I had to have an outside TBI nurse assist with the school that we hired to help us develop this individualized healthcare plan for Chris. So I'm only showing you a couple of pages. That's the title page. This was the one just for his gastronomy tube and his feeding and his hydration. This was for his baclofen pump. You had to be aware of what it was for and that it could fail and what the signs were. And this was with regard to using his wheelchair. You think, well, I know how to push a wheelchair. No, this is all about what you have to look for. Maintaining his skin integrity, making sure that he's out of the chair for so many minutes a day, and not laying and sitting on the same area all the time. And then look at his team. Look at how many people were on his team. And medical still was very involved. Look at all the people there. So we really had a lot of people that we had to interact with. Now, here's what's really interesting. Again, Chris couldn't move any other part of his body but his eyes, but he was aware of everything going on around him and he understood everything that people were saying. But guess what? People who aren't used to that think that he's just not there. And as you can imagine, just like Alex, he experienced a loss of normal everyday routines. He, attending school, caring for himself, all of those things changed. He was unable to participate freely in physical activities as a boy his age would, and as he did prior to the injury, and he was very aware of the loss of function. He worked so hard in his therapies because he really wanted to go back to school, and he was also very anxious about it. So these are the supports and services we put in place for Chris. We had a special education teacher case manager who was assigned initially just to him. I know that sounds crazy, but that was what we needed to do. Then she would go into the small SDC class and teach alongside the SD teacher, but he really didn't fit in there. And that made it difficult. So we integrated him into 2 general ed core classes, 2 hours per day, but only 3 days per week. And we modified and made accommodations and lessons accessible. We facilitated socialization and include him in some of the collaborative groups that were going on. We consulted and supported with the therapist, the RN, and the paraeducator. He had his own nurse also, who did the G-tube feeding, the diaper changing, the stretching protocol, the medication, took his vitals, did his transfers and positioning. And his paraeducator supported with academics, therapies, and nursing support after the special education teacher started to phase away. Here's an example of Chris in his therapies. Some of these were school therapies and some of them were outside medical therapies. The most important thing we had to make sure we did was communicate. Chris utilized a multimodal communication approach, high and low tech devices. Okay, and picture communication cards, an eye gaze board, a speech generating device. This was his device. It was a PRC Accent 1400 with new eye, which was introduced in November. And after 5 months, here are the things that he was able to do. A miracle. No one ever thought he would be able to do this. And I just love this slide because if you look at all of these pictures, you can see the various ways that augmentative alternative communication opens the doors to people who have physical challenges. Not being able to speak is not the same as not having anything to say. Chris's passport and student profile looked a little different from the one we developed for Alex because we did an issues and strategies approach. And I'm not going to go through these with you, but I want you to see we addressed all areas. Communication issues and strategies, here were the issues, there were the strategies. Gross and fine motor, issues and strategies. I just want to point out proper positioning is so important for children who use a wheelchair. And those are the reasons why. And oftentimes I see kids slumping all day and no one repositions them. He had vision issues, and those were the strategies. So you can look through those at your own leisure. He had social emotional issues, and those were the strategies. Most importantly was to talk and to treat Chris at an age appropriate level. And to facilitate access to typical peers. We did a lot of that. And then behaviorally, you know, how you figure, how does a kid in a wheelchair who doesn't move misbehave? Well, how about close my eyes and make believe I'm sleeping, or lower my head and stare at the tabletop, or turn my head away? And so we came up with the BCBA how to come up with the strategies he was willing to work for. And then the academic issues and strategies as well. We really worked on those, and we provided a lot of support for him so that he could participate, not only in the small class, but also in general education. IEP goals were very scattered. It's very interesting. Yes, he was sorting like maybe a young child would, but he was also working on vocabulary that was appropriate for his grade level when he went into general ed science class. And most of our work was really getting him to engage, to increase time on task, and use his AAC device to communicate. That was really the biggest thing. So we wrote a lot of goals for him. Here's a picture of Chris being integrated into his 6th grade general ed science class. On the left was the aide. The person in the blue was his one-on-one RN. And yes, he actually had an RN level instead of an LVN. Most schools have LVNs, sometimes a certified nursing assistant, but he needed that level of care. And so he participated in the hands-on activities. So the other thing we had to do for Chris, and you should do for children with moderate severe, is make sure you refer them to the state councils on developmental disabilities. In California, we call it Regional Center. Here's a list of all the services they can provide. And as they move through high school and are getting ready to exit, most of these kids will probably stay through their 21st birthday. We do want to hook them up with Rehabilitation Services Administration. And then also they are disabled, and therefore they qualify for SSDI. And TBI was finally added to the list of impairments in 2016. So to finish off, I want to just talk a little bit about developing IEPs with appropriate goals and strategies after acquired brain injury. And this would apply to kids with traumatic or non-traumatic injuries. So first of all, let's make sure we carefully craft them to focus on things besides reading, writing, and math. Relearning how to learn and how to compensate for those skills or behaviors that may forever remain challenged for the student, but we want to make them the primary goals of their IEP. Cognition, compensatory strategies, and memory, attention, and concentration. We tend to say, oh, they're going to use these strategies, but do we teach them how to use them? Do we make those a goal? Behavior and social skills. Executive functions are so important. Do they know how to identify their own strengths and weaknesses? That's why we developed that document that Alex fills out so she can say, well, I was a 1 today, or I was a 10 today. And then when she says, well, I was a 10 every day or every period, you say, well, what about when you happened with this? So that's really important. Setting goals, planning tasks, initiating activities, self-evaluating, problem solving, and organizing, all important. Key strategies: keep your goals functionally and oriented and outcome-based. Write goals and objectives for attending to task, or for learning to shift from one task to another, which is very difficult for many of these children, or following simple 1, 2, 3-step directions, or using specific organizational memory and problem-solving strategies. It must be important because I've already said that. And IEP amendments may need to be held more often as students' needs change. Also, really important is teaching new concepts and skills to individuals with brain injury. It's so important because new learning is much more difficult than, as I mentioned earlier, than regaining skills that were lost that they had previously learned. So we want to create a positive setting event, both external and internal, before requesting students to engage in difficult or new tasks. So we want to follow a strong, consistent lesson plan format that we're all taught as educators for teaching new skills. We want to use guided instruction. Guided instruction, connect to previous learning. Now, sometimes memory problems are an issue with that, so we may have to remind them. We want to model. My turn, watch me, I do first, don't do anything until I do it. Guided practice. Our turn, we do it together, we do it together. Repeat until solid. You don't just do it once. And then independent practice. If you get there, your turn, you do. Ensure that all requested activities are doable. Remember that just because you taught the skill yesterday does not mean the student retained it. And then most importantly, teaching GIST in the classroom. I've been mentioning GIST a few times today. Some of my favorite people, Lori Cook, Roberta de Pompey, and Sandy Chapman in 2011 wrote an article on teaching GIST in the classroom. And on the left, you'll see all the different ideas. And on the right, here's some way that you can teach it. And a lot of us are already doing these things, but we didn't know to call it that. But it's really important. It's the biggest piece of misunderstanding where the kids start to lose the connection in learning. We also want to use universal components to develop positive behavioral intervention supports for children with moderate to severe acquired brain injury. They need clearly defined schedules, positive behavioral supports, routines, scripts. We want to encourage and reward expected behaviors. We want to ignore and not reinforce inappropriate behaviors. We have to make data-driven decisions, and everyone has to be on board, everybody. And for students with moderate, severe, acquired brain injury, with planning and training and accepting attitudes by everybody and teamwork, impossible becomes possible, unable becomes able. Thank you. We're going to have some questions. Here are my key references.
Hi, Sharon. Thank you so much. I do have a couple of questions from folks that put them in there. The first one that I have is actually from Gina Piccolini. She said, thanks for sharing all of these resources. How did you get the school to assign a one-to-one case manager for Chris? From a staffing perspective, that is magic. How did you do it?
Actually, the whole IEP team came to that conclusion because his needs were so intensive. She started off as his home hospital teacher, and we were starting to do a transition, and she just had to stay on a whole lot longer. One of the things that I recommended was that there was a transition time where there was overlap. And when we did the overlap, they realized that he was such an intensive need child that we needed her there. But we eventually faded her back.
Thank you. And Deborah said, you might address this later, but do you have suggestions for interventions for young teens with post-TBI impulsivity who really like board games and video games? So games that can help these very impulsive kids practice these skills.
You have to tie everything to a reward system. Even adolescents. You would think that no, adolescents don't want to earn something to, stay on task or to think things through. I do use a stop and think strategy, oftentimes because they're so impulsive, and have them count. And they often need a lot of help doing that, and we have to model it with them, very much like we do the my turn, our turn, your turn. So that might be a couple of ideas.
Thank you. Carrie would like to know how TBI relates to trauma and how do you ferret out the differences?
So if I understand the question correctly, so a brain injury is traumatic, whether it's from whichever way it's been acquired. A lot of these children do have what we call, maybe you're referring to post-traumatic stress as a result of having gone through the injury, and the effects of the trauma, of the emotional part of that trauma. So brain injury and PTSD go hand in hand. Sometimes it's not identified in children, and as educators, we don't identify it. The medical community has to. So we may say we see symptoms of it, and share that in our notes that we send back and forth to mom and dad on the log, or our nurse, who hopefully has to have a relationship with the physicians that are treating the child, because they have to have communication with them in order to fill out the to develop the healthcare plan. So we're hoping that the nurse and the physicians are communicating, and that we can share what we see.
Okay, thank you. Yeah, it looks like her follow-up was definitely about the trauma, not related to the TBI. So,
Okay.
I have an anonymous attendee that says, would the ABI temporary school accommodations plan be appropriate with a mild ABI with a 504 plan?
We have one developed for the mild TBI. So the answer is yes, it's just slightly different. It has less things on it, it doesn't include all the intensive things. But we have one, and I know that we can get that available, make that available.
Great. And then Elizabeth asks, when do you recommend private school placement versus public school for kids that have ABIs?
That's a loaded question.
Yeah.
I actually worked in a private school for children with acquired brain injury. And after a couple of years, I realized that the reason the kids were coming to us were because the school didn't really have the expertise or the training. So I actually started my own practice, and became a consultant to schools to work with them. Now, some states like Pennsylvania and Colorado have the Brain Steps program. So their goal ultimately is to keep as many of those kids who've had a brain injury in their schools with the appropriate supports and training for their staff. It often happens when there is no training, and there is no consultant to bring in, but many times they don't know that, and they keep them anyway. They typically are sent to a non-public or a private special ed school when their neurobehavioral issues are such they cannot be managed in the school even after ABA has been put into place, or positive behavior intervention support plan, and they are danger to themselves or others, or they're disruptive to the learning environment.
Okay. Thank you so much for answering all of those questions. It looks like we got through all of them. So if folks do have follow-up questions, did you have a preferred contact that you would like to have them contact me, or do you have an email you would like us to distribute for you?
I'll have them contact you, and you can send me the questions. I'll be happy to answer.
Okay, absolutely. So as I put in chat earlier, for anybody who has questions for me, and hopefully you all also got the handouts that I sent out to you. My email address is pereza@severity.org. If you do have any questions at all, please don't hesitate to email. We are always happy to offer supports and connect you with folks as works best for everyone. So Sharon, thank you so very much for that.
It was my pleasure.